Welcome to another episode of Cobb and Company, the podcast of the W. Montague Cobb Health Institute. Being recorded live at the National Medical Association Annual Convention in New York. My name is Rolf Taylor. I am the producer for this series. Over the coming months, we'll be featuring thought leaders in areas such as health equity and initiatives such as increasing diversity in the healthcare workforce and initiatives increasing diversity in clinical trials. Today, it's my great pleasure to welcome Reverend Dr. Lucy Perez to the podcast. Welcome, Dr. Perez.
Thank you.
Or
Thank
should
you
I
so
say
much.
welcome, Reverend?
You can say Lucy, you can say Nana, you can say anything you want. I am grateful to be here and because it's such an important topic. It's such an important time. The fact that this is occurring where the greatest minds, the greatest thought leaders on health for Black people are concentrated between these two. I mean, it's just amazing.
It is remarkable. And of course, the Cobb Institute is named for one of the greats, Montague Cobb.
Absolutely.
Now, did you happen to meet Montague Cobb?
Not only meet him, and as you're saying his name, unfortunately, I wasn't one of his students, but I met him politically through the House of Delegates. And I was a newbie to the House. And I was very concerned about some of the political things. And I can remember Dr. Cobb quieting me, relieving my anxiety when he said, New York's going to make a deal with California and everything's going to be okay, Lucy. And I saw a delegation from New York go and negotiate with California, and everything was okay.
Wow.
What a man. And then I followed him to the NAACP. You know, he was president of the NMA and also president of the NAACP. And at the time we were holding hands, or he was holding my hand and comforting me. I did not know the giant to whom I knew about him in the NMA, but I really didn't know what he had done for the NAACP and, just.
And it's really interesting. I know that Dr. Morgan is so passionate about maintaining an understanding of his impact and maintaining an understanding with younger generations of what a remarkable trailblazer he was.
And one who served. I am sure with his brilliance in anatomy, he could have gone anywhere on the globe and put money in his pocket, had at least 8 to 9 sleeping hours every night, plus at least a month or 2 of vacation with his family. But he served us.
Yeah. The work was too important.
Too important. Mm-hmm. It drove him.
Yeah.
And
so I think the frequent remark about Montague Cobb that I'm hearing over this weekend and the interviews we've been doing is that he was so many things. He was a physician, he was a scientist, he was an educator, he was an activist, but he was also a musician.
He was a musician and a mentor. A mentor. I mean, Howard educated such and then educated even a larger percentage of Black physicians who didn't know him. He's just absolutely remarkable.
Fantastic. Well, we've gone off on a little bit of a tangent.
Okay, Montague Cobb.
Because I did want to tell our listeners a little bit about you, before we get back into discussion. So let me just share with our listeners a little bit of background information. So Reverend Dr. Lucy Perez is a former president of the National Medical Association. Which year was that?
And 2001 to 2002.
And a former director of the NAACP.
Absolutely. And, the year. So that was 2004?
You began your career in New York State. You worked in public service for the first 10 years after graduating, including at the New York City Department of Public Health,
Yes.
where you began programs for adolescent parents and those adolescents at risk of substance abuse and HIV/AIDS.
Absolutely. Prior to my tenure there, it was child. So what I had the wonderful opportunity to do was to bring in the importance of adolescent medicine to the city health department, which is responsible for the health of children in public education in New York.
And that really wasn't happening at that time?
Prior to that, it was children, and then you became an adult without a time in which you could actually begin to lay down good healthcare maintenance, to understand the importance of taking care of your health, plus all of the risk factors of adolescence.
And as the decades go by, and this is another tangent, as the decades go by, it seems like more and more we're recognizing that, true adulthood doesn't necessarily start at 18. It really, from a neuroscientific perspective, executive functioning doesn't really complete its development until late 20s. But we just throw people out into the world like, okay, go on, get on with it.
And the more educated, the later what we call late adolescence occurs, because for many young adults, they are still so dependent on their families. And so for that free independence, we push it further back, especially if they, get terminal degrees and fellowships and things of that nature.
Yeah. Long education.
Long education.
You became an activist for AIDS research in the Black community.
Well, because of my relatives, and I am preceded in the presidency by my maternal uncle, Vernal G. Cave, president in 1975. He also, I thought that physicians had to be social activists. So I thought it came with the territory because of the shoulders of the people I stand on.
And there's alternative viewpoints, or you could say a reactionary viewpoint to that, which says physicians should have nothing to do with that. Physicians shouldn't even have anything to do with social determinants of health, right?
Hey, that's what we've been doing. How has that worked for us? Not very well. And I was also a member of the Black Panther Party. My assignment was then to teach people who were addicted. They had what they called kind of a no drug, no intervention, all behavioral standpoint. And so my responsibility was to teach them to read. I was still in high school. And as you know, the Black Panther Party started, and it was during my time that I was in the party, started the breakfast program. I don't say free breakfast program, I say the breakfast program, because we made sure that everyone in the community fed the children before school.
Mm-hmm.
So that I remember at one time my detail was to stay over the front door of an apartment. I remember it was a gentleman who had never contributed to the breakfast program. And so Panthers came, they wrapped him up in his sheets, and he came down and he was either flipping pancakes or making oatmeal or something, because it was a driving principle that we all had something to do. There wasn't, the groceries, the local grocery stores. If you want to have any customers that don't have to go through a line of Panthers at your front door, how many dozen eggs are you going to contribute, loaves of bread? So it was getting everybody involved.
And your career has been marked also by research, right, into health disparities. You researched racial inequality and injustice in medical treatment, including in analgesia and the long-term effects of this disparity.
And one of the things that the NMA through, that we did, we put out papers, we followed that. It was significant work. As you mentioned, I had the opportunity to be the medical director at the Center for Substance Abuse Prevention. So able to send out many, many grant programs where we looked at many of these things associated with substance use and abuse, and the disparities that were generally associated with Black people, such as I think one of the issues was how disparagingly we looked at young Black women who came into the emergency room with abdominal pain as compared to a white young lady who came in and
and that was strictly bias.
But it was bias.
Yeah.
And the bias was regardless of the race or ethnicity of the provider of the care.
Yeah.
So it was the whole systemic nature of what we're talking about. It's not on an individual basis.
It's embedded.
Yes, embedded.
Yeah.
You
So the research you did with the National Medical Association on this subject, you showed that people of color were stereotyped in receiving medical treatment and were at a greater risk of depression and had longer recovery times.
Absolutely. And I think that speaks to what the Cobb and the NMA has done. There was a blending. I was supported because I had the brilliance of anesthesiologists. I had neurologists. We used to call them sidewalk consults, but everybody wanted to bring out, even though this wasn't a quote unquote clinical trial, wanted to have the baseline research to make sure that the questions that the community wanted answered were answered, so that there's always a bidirectional movement of information. I think NIH now, some 20 years later, are actually providing resources for translation of scientific information to the community, which I think is such an important component.
So making that information accessible.
Making that info to everybody so that you understand it. And I think that is why, as we move forward with the Cobb and we begin to get people more involved in clinical trials, during the time that this research, that a little bit of research that I did, but that was around unequal treatment, confronting racial and ethnic healthcare disparities. And that was spearheaded by Jesse Jackson Jr. in Congress. He got the Institute of Medicine to do that study. And that study proved that regardless of class or anything, the healthcare that Black people received was inferior to their counterparts. And go ahead.
So that was in 2002?
2001. Yeah, 2001.
So if you were comparing Black and white patients of identical socioeconomic means and resources,
Mm-hmm.
there's still a disparity.
Absolutely.
And how do you explain that?
Racism. And, and now because, I was so impressed by the book Cass and the implications there and looking at it at a totally different standpoint. I always looked at race from the standpoint of black and white and, being the cohort of it. And I say cohort because even the studies in unequal treatment, which was done by the Institute of Medicine, the study I was talking about, it was over 100 research studies that they analyzed and compiled for that report to Congress. The definition of race was black and white. There were, ethnicity and things of that nature didn't come into the discussion. It's just coming into the discussion now, those sensitivities. Now we're talking about gender. And when unequal treatment came out, the National Medical Association actually looked at how this was playing out by media. And it only got attention for 3 days.
Wow.
3 days on major outlets compared to what happened with COVID. And we saw because we never addressed any of those issues before the institutional racism, we saw over 1 million people die. And we knew that the system, our public health system was in shambles. But now what are we doing?
Overwhelmed. Yeah.
Oh, overwhelmed. But we knew that was a mistake. We allowed people to die because of systematic racism. But yet, those things that gave people access to primary care, we've shut them down.
Took them away.
So we knew what worked. We hurried up and we did it. And now it's not a problem. So we'll go back to the way things used to be. And that's why we cannot miss this opportunity in the election of Kamala Harris as our next president of the United States to make sure that in these 4.5 months till Election Day, we are ready to put in place those things that will improve the health of our community while people are looking for our vote.
Yes, it's a moment of leverage.
It's a moment of leverage. And the brilliance that's here at convention and scientific assembly, which is important. So it's not just the politics of NMA, but the scientific assembly. It's critical. And we're ready. We're prepared.
And if you're researching health disparities and you're defining health disparities, then you have evidence.
Oh, yeah. We absolutely do. I heard from his own mouth, translated by my daughter, that you have to have the will to. Fidel said that when he assumed the presidency in Cuba, that, all the brains left, all the money left, and yet they eliminated illiteracy. Their infant mortality is much, much lower than ours. Their maternal mortality,
They educated doctors. More doctors than they needed.
And not only in Cuba, but 70% of the doctors at the time, this is 15 years ago, 70% of the physicians in sub-Saharan Africa were educated through Cuba.
Incredible. Yeah.
The NMA, of course, we had a delegation that went to Cuba, and for the first time, I really appreciated the difference between being poor and having a poverty mindset. So in Cuba, I saw poor people, but they didn't have a poverty mindset. It was everybody. It was for the good. Everywhere you saw evidence of the revolution.
Yeah, amazing.
Yeah.
Yeah. So in 2002, you were ordained in the African Methodist Episcopal Church.
Yes.
And since this year, you are serving on ministerial staff of Kingdom Fellowship AME Church in Calverton, Maryland.
What?
Tell me about that. Tell me what are you doing in that capacity as the reverend?
Not what I'm doing, what the church is doing for me. And this isn't the spring of my life, okay? I'm probably closer to winter, even though I think it's fall. But I mean the church, the pastor Matthew Watley has got, oh my goodness. It is the fastest growing church in the United States. Okay, everybody's talking about churches closing and everything like that, but he has staff, he has a vision for doing what I believe Jesus's mission was. It's real Christianity.
Real Christianity.
Real Christianity. And I'm blocking on his name now. Pastor of Glide Memorial. Oh, should have looked at it. Glide is in San Francisco. It's a church. CSAP, Center for Substance Abuse Prevention, supported them. I'd never seen anything like that. In fact, I had the opportunity to do some pelvic exams in between 8 a.m. and 11 a.m., do bleach and teach between 8 a.m. and 11 a.m. They were serving food. They had people come into the church to, much different from now so that they could have access to computers, to do resumes, to search for jobs, just so much. Just what the church, I believe, is supposed to be. It's not just an edifice to come and I think praise and sing to God and to hear a word and to understand that word, but to do.
To live.
To live and to love. Because that's what it's all about. It's the love, because the love gives excitement. It's the love that heals. It's the love that heals.
Yeah. Celebration of being human.
Yeah, being here with you is healing for me.
So let's talk about the work that you've been doing and the opportunity when it comes to diversity in clinical trials, because I know you've been making that happen in the context or in the environment of your church. How have you put that together? How has that been working?
Well, I'd have to say it's really not me. Again, I tell you, the visionary, Pastor Matthew Watley, and the fact that he's trusted. He's trusted. I guess our sit down in person. We meet 8 a.m., 10 a.m., and noon. That is a minimum of, I'd say, 5,000 people. Then we have at least 10,000 online.
10,000.
And
wow.
they're trusted by him. And Be It Resolved is the sermon series that he's working on. And July, now this is August, beginning of August. But part of it is he put out the word about clinical trials. And not only is it important for the information at the end, at the end of the trials, a new medication, a new device. But he says, is that not what we're supposed to do? That we have an opportunity to be a part of God's glory.
So you're saying that a scientific discovery which benefits people is really part of God's glory.
Yes.
That's such a forward-looking way to frame medical research in a faith context.
Matthew Watley does it. Because, there is a piece of scripture that says that God will give you more than you could ask or think. The fact that the think is there means that you have to be exposed to it. If you haven't been exposed to the information, you can't even ask for that. You're ignorant of it. And I think a different interpretation of the same text comes with a different type of exposure. And being able now to have so many people from different socioeconomic groups and genders and preferences, all of that, who trust their pastor to say, look, let me see how I can be used. Because entering in it can push you into a more intimate relationship with the Lord. That because that's what it's all about. How we show up with Him.
If you're participating in the expansion of knowledge,
yes,
it's a beautiful thing.
It's a beautiful thing. It's a beautiful thing. And that intimacy, that reward that you get, that personal, I would appreciate a hug from you, but a hug from Jesus? Oof. Who can beat that?
It's interesting, isn't it? Because one of the things we say is clinical trial. Well, trial's not the most positive.
Trial isn't.
So I'm wondering, when you communicate with the congregation and you're raising awareness that there is an opportunity for you to participate in a clinical trial, what are the messages that resonate with the congregation? What do people connect with when it comes to talking about medical research?
I remember one of my good friends' father was part of Bidal, which was the only drug that the FDA approved for the use in Black people. Bidal. It was for heart failure. It was a combination of two drugs. I don't remember what the two were. They were well established, but it was one of the best conducted clinical trial studies. I mean, you go to phase 4 and you still had 90% of the people still in contact, which is unheard of. But their providers had their trust. It came out of ABC, the Association of Black Cardiologists, I believe, and just such a unique study. At the time, I really was able to use, not that I had a lot of clout, but a little bit of my clout from the Center for Substance Abuse Prevention with arguments that came from the FDA and NIH that really pointed to the white supremacy and the racism associated with how the drug was rolled out.
Yeah. But
as a Black-only drug, good for African Americans, it repelled Black people from even wanting to participate. Do you understand what I'm saying? And the venture capitalists associated with with the manufacturing of that drug, they backed away too. So it was almost as if it was a setup.
I don't know this story, but am I right in am I hearing you correctly to say that some medication was contraindicated for Black patients?
No, the opposite.
And in this case, it was contraindicated for white patients.
There was no contraindication. It was just the drug worked so well for Black people that, and one of my girlfriend's father was taking the drug. He felt better than he had ever felt. I mean, it was end-stage cardiac disease. He was in cardiac failure. So he had had many complications before, and this alleviated many of them. And so it was, and it wasn't novel compounds. It was drugs, the fact that they had put them together. And it had such a positive effect on the cohort. But the positive effect was on the cohort of Black patients. And ABC, that supported it and everything like that, just all of the good things that we are now talking about were associated with this, but they killed it. And I think purposely, because, and at the time we knew that so many other medications didn't have a representation of Black people.
Because they just weren't studied.
They weren't studied.
Just the data wasn't there.
The data wasn't there because that's right. The outreach wasn't there.
And it's not a biophysiological problem alone. It's a problem of inclusion.
Absolutely.
It's a problem of if you don't have any of that population in the study, then you've already segregated the medication.
Absolutely. Or you say, okay, well, we don't know if it works on you, but take it anyway, because we don't have anything else. And then you usually don't get it because you have the 15 years that it's the trademark or
the patent time. And the patent time runs from discovery. Yes. So by the time you're on the market, you've already lost half your patent time.
Absolutely.
Often. Yeah. And now we're in this era where we're increasingly advocating for removal of race-based medicine.
Mm-hmm.
And things like EGFR
mm-hmm.
are now we're realizing the race coefficient in that was harming generations of Black patients.
Absolutely. Same thing with obesity. We looked at, obesity and we said obesity, hypertension, all of those, oh, you're Black, So you can have a higher systolic or diastolic rate. So and that was some of the bias. So similarly, as a pediatrician, the way patients with sickle cell disease came in crisis and pain and, you're Black. You can handle more pain.
Right.
If I give you pain medication, I'll make you an addict because you're susceptible to that.
And
because you're Black.
There's also a gender bias with pain.
Gender.
You can, for women who have children, you can put up with pain.
Absolutely. Maternal mortality. I mean, isn't this country embarrassed that the United Nations has to point out racism as it relates to maternal mortality? That's embarrassing. That is absolutely embarrassing.
It's just shocking that it's been normalized. And that's unfortunately a human phenomenon that we see in so many instances.
Mm-hmm. Absolutely. But, like this podcast, information is power, and information that's shared with the community, information that's shared we get a synergistic kind of exponential movement from that.
And podcasts have now overtaken talk radio.
I didn't know that, but I could see that. Why? And that's so important.
It's really interesting because podcasts it's a process of a listener choosing to listen to a specific subject. And that's very different from, say, NPR.
Right.
Where you listen to NPR and it's very high quality programming, but you're not really having much choice about what you get to listen to.
Right.
It's a constant stream. But podcasts are self-selected.
Right.
And I think that's part of the reason why they are now overtaking talk radio, is that people do want to choose the subjects. They do want to self-educate.
And dig deeper.
Yeah.
So if there's something, I know for me that, a deeper dive after I've heard something, I don't know if that's consistent with my experience. And then you want to go, you want to hear, you want to listen to.
And then I think a parallel with the church is that a podcast convenes a community of listeners. And they're not talking to each other because the mechanism isn't there. But they do know that lots of other people are as interested in this thing as they are. So it's kind of this convening part of podcasts, I think, is very positive.
Wow. Right.
And then for, what you're saying about trust and, the congregation trusts the pastor.
Yeah.
It's a trusted source of information. And I think with podcasts, because it isn't written text that could be anybody or could be a computer.
AI.
Right? I guarantee you and I are not AI.
No. But you're absolutely right. Yeah.
I'm hopeful that we're entering into an era where communication is getting better. And the fact that somebody can listen to our conversation on their phone with their headphones while they're doing whatever, they could be taking a walk, they could be doing anything.
In traffic.
They could very likely in New York or Maryland even. But that aspect of human voices and how positive that is, the positive way to receive information. I'm excited at what we can do with the information that we're sharing and how beneficial that can be.
With a podcast, with this conversation, we can then take these conversations as jumping off points. One thing that we have at Kingdom Fellowship, again, are small groups. And so because it's such a big church, Pastor wanted to make sure that there were small groups that get together to talk about the sermons, to talk about what needs to be done, to talk about life, all of that. And, maybe 5, 10 people. And then they become a small little group. It could be on anything. They have mountain climbers. They have fashionistas. They have any kind of group that you could think of. And you could start your own and then publicize that for people to join in. And a podcast is a phenomenal opportunity to get the discussion started.
And you're wearing both your hats as a reverend and a physician, and you're talking about health and clinical research. In addition to the things you just mentioned, it's an extremely contemporary portfolio of interests. Does that explain, do you think, why, even though overall congregations are actually falling in America now?
They are. They're shrinking.
But that's not the case with your church.
No. When we look at some of the things that are major issues now, especially following the pandemic, mental health issues, alienation, loneliness, suicide, all of those things cry, help me. Connect with me. Love me. See me.
Yeah.
I mean, what? Are we deaf?
Yeah.
It's screaming out. Connect the dots. We're disconnected.
But I think it's, just to go back to something you were saying about, people are finding life difficult.
Mhm.
And we're in the moment. We're not at a point where we're looking back and saying, well, we can figure this out. We can understand what happened 5 years ago, why people were feeling a certain way. When you're in the moment, in the present, it is more difficult to fathom what needs to be fixed.
Right.
And things are changing so quickly, particularly the way technology is affecting our lives, that we're playing catch up in terms of adapting.
Yep.
And you have to figure out how to adapt. And I'm sure in the environment that you are building in your church, that you're actually creating a space where people can reflect on these things and that adaptation can take place. Because it's not automatic.
It's not. And, especially congregations, which is so different from in Kingdom Fellowship. Usually you see older Black women. That is not true in this church. There are so many men, so many young people. It's just so refreshing. And you know how men are.
I have a few years' experience.
Yes, you do. You all are. You keep your feelings on the inside, and
Yeah.
so it takes more work, I think, or not work. It takes more intentionality.
It does. Yeah.
And so and we're getting there. We are God's plan A, and there's no plan B. So we got to get it together.
Yeah. We got to figure this out.
We have to figure this out. And you said adaption. And I guess for some reason the word adaption, like assimilation, are words that kind of push you down. They don't leave room for revolutionaries.
Yeah, because it's incremental, it's gradual. Yeah.
And how we nurture and support creativity.
Yeah. Yeah. I was just looking at a lovely description of the difference between STEM and STEAM. So you've heard of STEM?
Yeah.
I'd heard of STEM. I'd never heard of STEAM.
No.
Well, it's the addition of the word art.
Oh, yes. I did read something about that. Yeah. I did. That is so important.
So my daughter is 26 and
you had it when you were 3.
And so I sent her this little thing just saying, oh, look at the difference between STEM and STEAM. Isn't this important? And she immediately texts me back and she's like, oh my God,
what?
This is the emphasis. This is how things need to be. And I thought, wow, I don't usually get that response from a text to her. Oh, Dad, you're so lame. But no, it really resonated with her. And I think that's, it's like, if you're going to adapt to changing things,
yes,
you do need to have a more creative mindset. You need to be able to embrace those things in a creative way. And that's, again, it's really part of being human.
Could be able to, and have it express. Have it, the creativity, the artistry. I don't know if you've been, well, is it here? I don't know where.
The Hilton with the art exhibition.
The marketplace.
Yeah.
Oh my gosh. Amazing. Just absolutely amazing. But you can see in that maybe what what we haven't been able to verbalize or be or see my hurt. Just and just at looking at that, be seen, see that part of me that, and then to see something else that just makes me stand up straight, just
Celebrate the beauty.
celebrate the beauty. And the spoken word at our opening. Were you at the opening?
I think I was recording.
You will, but I'm sure it's recorded. But listen to the spoken word at our opening ceremony. I mean, everybody, all the awardees and what they've done, and all of that's important. But that spoken word was just delicious.
Well, I am sorry to say, because I could talk to you for another few hours. Quite happily.
I know you have to.
But we're going to have to wrap things up. Just in terms of your advice, maybe, to our listeners who are, people who are connected to NMA, people who are connected to the Cobb Institute,
Mhm.
in encouraging engagement around health and medical research, what would be your advice for people just to think on in terms of how they can do that more effectively?
Right now, my answer would be to secure time, because people in Cobb, people in the NMA, people in ministry are very, very busy. But if we do not secure time, like when I secure time to read the word, it, how dare I rush the Holy Spirit? Come on, God, I got 5 minutes. But secure time to think about it. To just say, I am going to spend this period of time on Saturday afternoon or whenever it is to really think about seeing ourselves personally in it. And then, that authenticity, that creativity that we all have, I think that brilliance will come out. And I'm going to spend some time from now, at least through this week and weekend, thinking of if there is an approach. I don't think there's any one, but securing time to think about it, really, and to maybe listen to a podcast and then take somebody else out for, high tea. I love high tea.
Oh, me too.
I love high tea.
Yeah, that's a good.
That
good
is
English
so.
tradition.
It is, and it's so sophisticated. I mean, it's a proper time to just.
Yeah. Finger sandwiches at 4 p.m. with a cup of tea. That's where it's
That
at.
is, yes.
That's it.
Yes, a scone.
And,
and churn butter. Oh.
And since we're neighbors, I'll make a promise to come and visit you at your church at the Kingdom Fellowship in Calverton.
Okay.
And we will have a part 2.
All right.
Let me come and witness what you're doing.
Oh,
we'll talk about it.
Wonderful.
How's that?
Wonderful.
How's that for a plan?
That's a plan. And I'll get high tea and definitely have high tea with Pastor Matthew Watley. Okay?
Yeah.
Oh.
Thank you so much for your finding time to talk with us.
Yeah, it was wonderful. I hope you can get something from it.